about how I wanted to go into medicine in one way, like one form or another, and they actually both recommended the PA program. So, I had a general sense of what it was. I think part of me was just saying yes to many things that year. But once I was in the interviews, I realized how much I wanted to be a part of the program.
And that was the PA interviews?
Yes.
Okay. So what were some of the things that your uncle and your, was it your aunt that was the nurse practitioner?
Yeah.
What were they saying about the profession that made them want to recommend it to you?
I think quality of life was the biggest thing. So I think, my aunt coming from the advanced practice side and my uncle coming from the physician side, both recognize that, with PA you kind of get best of both worlds. You can practice medicine, but you also can choose how much you get into it, and you can switch specialties if you want to. You can choose to work call or not do call, whether, whatever your preference is. So they kind of know that I'm the type of person who has many different interests within and outside of medicine. So for me to be able to do something that allows me to maintain all of my other passions was a big deal. And I think their other point was that you literally have 2 years of schooling after your undergrad, and if you don't like it, you can move on to something else, or if you still want to do more schooling, you can. It's not like you're investing, a decade of your life into it.
What was your background in undergraduate study before pursuing PA?
So I did a bio-psych double major in U of T. So it's actually called Exceptionality in Human Learning.
Oh, wow.
So it's a combination of disability studies as well as biology. And then I went straight to the PA program afterwards.
Were you considering other programs at that time?
Yeah, so I had thought about behavioral therapy, and I definitely thought about going into an MD program.
So how was your experience going through the PA program?
Oh, it was great. I actually think out of the 6 years of school that I had done, those 2 were my favorite.
Okay.
So in my first year, when we do those longitudinal clinical experiences, I had met an oncologist, and just the way she introduced oncology to me was kind of what hooked me. And since then, I had kept in touch with her. So throughout clerkship, I would try to do as much oncology as I could. I did it in Sunnybrook. I also went to Johns Hopkins and did a month elective there.
That's in the United States?
Yeah.
Oh, wow.
And even within my surgical rotation, you get to choose a selective. So I had asked to be put into surgical oncology for at least 2 weeks.
Okay.
Yeah.
And throughout that, you were exposed to different facets of oncology from different perspectives, which is great.
Yeah.
How did you go about setting up a rotation at Johns Hopkins in the United States, if you don't mind me asking?
So it was actually the oncologist I met in first year. So I went back for more experiences with her, just completely optional. And she actually was affiliated with Johns Hopkins. So I told her how much I really liked oncology. And so she not only set me up with a rotation there, but she set me up with a PA there. So I actually got to know what PAs were doing in oncology before they really even existed here in Canada. And I think I was actually the first PA, Canadian PA, to come there. So that was a really cool experience for them too.
Yeah, and I think there's about 14 or 15 of oncology PAs in Ontario.
Yeah, I think so, yeah.
Yeah, that's really neat. So you're definitely a trailblazer in that regard.
Yeah.
Did you need any special visas to get that set up to be in the States for, I'm not sure how many weeks, 4 or
so? It was 4 weeks, and I think all I needed was a letter. So a letter from Johns Hopkins acknowledging that I was coming there, and a letter from my school saying that I'm coming there for an elective, and so I just showed that at the border.
Oh, okay. Fantastic. That's
Yeah.
great. I was just curious about that because I know that some students do international electives, but I haven't known anyone to go down to the States to actually do it. What was your experience like when you got hired on for the oncology service?
So I think it was actually a pretty good transition because I did my last rotation there, my last elective before I graduated, and at that time they knew they wanted to hire me. So coming there was I had known everyone already, so it was just a transition from saying I'm no longer a student and that the orders that I write are valid.
Right.
Yeah.
How were you, I guess, oriented to the service, and how did they know how to use you?
So I think most of that came through my rotation. So when I first met people in the team, I would explain what a physician assistant was. And my supervising physician was just very open to it. Like right away, he was comfortable delegating things to me and kind of seeing what I was comfortable with, what he was comfortable with me doing. Once I started working at Sunnybrook, I actually put together a small presentation, like a PowerPoint, and I did it for the nursing team. I did it as well in clinic, even though I don't work in the clinics, just so that the oncologist could be familiar with me. But it certainly helped that they had experience with me as a student as well.
Mm-hmm.
So I had a few weeks where I went to different oncology clinics.
Okay.
So even though I haven't gone back to clinics since then, I at least went to each tumor site just to kind of see what their typical treatments are like and what kind of cases they see, and to even just get to know the physicians.
And for those that aren't that don't have a medical background, what is oncology?
So oncology is the treatment of cancer. So it can be done as an outpatient, it can be done as an inpatient. Physician assistants can be in any of the settings. It just depends on what the needs are of the environment. So I work primarily as an inpatient oncology hospitalist PA, which is a long role, but basically it means that I look after cancer patients admitted to hospital.
Okay.
So any complications from their cancer or from their treatment are what our service sees. And we were doing hematologic oncology as well up until about 6 months ago. And so we would even see new leukemic patients come in and do their induction treatments.
And you did mention goals of care. So can you explain a little bit about what that means?
So goals of care is when you are trying to articulate what's important to a patient. So what are their values, and trying to match that with their treatment plan. Mm-hmm. And also kind of seeing, what is available. There are so many things so many avenues you can go down with oncology. There are several lines of chemotherapy available. There's all sorts of radiation, surgery that might be possible. But then you also have to look at the whole picture and figure out how much of it is actually going to make a difference, not only in lifespan, but also quality of life for a patient. Because there are many patients who, might go through treatment and get so sick that it's not worth it to them to go through all of that if it means just like an extra few days or an extra month. And whereas for some patients, they might think that they really want all the treatments possible, even if there's a chance of it actually, making life shorter for them. So it's kind of trying to figure out that balance with them, and figuring out, how far would they want you to go if they're deteriorating? Would they want you to take them to ICU or do CPR? So it's all those really tough conversations, and trying to figure out what's appropriate for a patient.
And what's been your interest in oncology, or what's always drawn you to that specific specialty?
I think it's the combination of really interesting medicine and having a really human side to it. So I really enjoy the fact that we see really complex cases. Sometimes you're seeing some of the sickest people in the hospital, but at the same time, you really get to know them. And, I love getting to know people's stories. And so I think that, there's always something so authentic about being able to go through the hardest moments of life with someone and making it easier for them, but also learning some really interesting medicine, but also interesting philosophies of life from patients. And I think that's what drew me from the first day that I did kind of that shadowing opportunity in first year of PA school. And that's what's kept me going since then.
So what are some common conditions that you come across in oncology?
So we see a lot of febrile neutropenia, hypercalcemia of malignancy, we see sepsis, we see bowel obstructions, hyponatremia. We also see a lot of immune-related conditions secondary to immunotherapies that patients are going on now. So we see a lot of colitis from that. We see neutropenic enterocolitis as well, and spinal cord compressions or cauda equina syndrome. Yeah, those are kind of like our bread and butter.
And are you managing all of these conditions as they come across in the hospital?
Yeah.
Okay. And what are some more of the rare conditions that you do come across from time to time?
So because we are a tertiary care center, we see a lot of neuroendocrine tumors, a lot of paraneoplastic syndromes, a lot of like the more refractory leukemias and lymphomas. So we'll see a lot of people go through multiple inductions, and the complications get very intense throughout these. We see a lot of aplastic anemia as well, and APL.
Right. So if a patient were to see you, and I suppose they would be on the ward,
Mm-hmm.
what are some of the interactions, or what would they expect working with a PA?
So I don't think there's really anything that different for them to expect, from seeing a PA to seeing one of the hospitalists, because the way our program works is that, we have several hospitalists who see the patients, and there's me as well. So I'm seeing the patients that my supervising physician would have been seeing, but he's also doing a lot of administrative work because he's kind of the most responsible physician for the whole service.
Mm-hmm.
So, if a patient is seeing me, they would expect daily medical visits from me, any diagnosis, treatment I would be doing, any procedures. So we do lumbar punctures, we do paracentesis, thoracentesis, bone marrow biopsies. So I would be doing them if they were my patient. We would be talking about their goals of care. We would talk about any like discharge planning. So all of the things that they would expect to see from a doctor on the team, they could also receive that from me.
Are you involved in family meetings?
Yes. So if it is one of my patients, so I see about 8 patients a day. If it involves one of my patients, then usually I'm running the meeting, or the social worker is, and I'm acting as a close right hand, providing all the medical updates.
Can you sort of walk us through how you would start a typical day at the hospital?
Sure. So there's no real like structure or schedule to it. Usually we start at 9 o'clock. I come in and meet with the rest of the hospitalists and my supervising physician, and he basically divides up the patients amongst us. So typically the hospitalist will see 12 patients and I'll see 8. And then after that, we each go in for bullet rounds where we discuss our plans for our patients with the rest of like the allied health team and the team leader. And then throughout the day, basically I'm seeing patients. I see them in order of acuity, so whoever is least stable gets seen first. And then I try to save any family meetings or procedures for the afternoon. And lately I've also started a research project in hospital. So I'm co-principal investigator for a research project within our ward. So I usually work with the research assistants and try to guide them along the process in the afternoons as well.
So is your schedule typically 9 to 5, or do you ever do evenings, weekends, call?
It's 9 to 5. I think that there could be the option to do call, but typically because we do have residents doing it, I've been able to avoid that, which is nice.
So what differences has the department noticed since adding a PA to the oncology department?
So I think the biggest difference would be that my supervising physician is able to dedicate more time to administrative work. Typically, he would have to split his time between seeing patients, overseeing the whole service, and then having to kind of go back and do the administrative work. So now he's been able to assign his patient load to me while he attends to everything else. So I think that's really helped our group function smoothly. And I think that our group has been able to evolve because of that.
What do you find challenging about working in oncology?
A higher likelihood of burnout. I've definitely found myself feeling emotionally burnt out at times. But I think that that's where, you have to kind of do a lot of self-care and also really remember the moments where you've made a difference in someone's life. I think it's it gets difficult if you feel attached to a patient, or you meet someone who's young, who just started their life and are diagnosed with very serious illness. So I think those can be difficult. But I also feel that when you feel like you've made a difference in their life and that you've maybe made this horrible situation a little bit better for them, that it's also quite rewarding.
Are you in a situation where you're breaking bad news, or is it
Yes.
they're sort of in sort of the later stages with patients that you're working with?
It's really a variety.
Okay.
So I do feel that, and I think that the bad news doesn't always just start at the later stages. Sometimes
Necessarily.
Yeah, sometimes, if there's just progression of disease, or if someone has a new diagnosis, like those are all really heartbreaking scenarios for a person. Or just even, if they lose function of their legs, they could live for another year, but if it means that they're not walking, that's also equally devastating for someone. So I've definitely had to break bad news, and I think that was one of the overwhelming things. During the first year of practice, I kind of thought to myself, like, I'm 23 years old, and, I've been breaking a lot of bad news, and it's very difficult. But I think, one of the palliative care physicians I met actually said that, her job makes her feel like she appreciates life even more. So, when you look at it from that perspective, sometimes, like, I think that it's a job that really, like, keeps you grounded.
Absolutely. And so what kind of PA or person would do well in a field like oncology?
I think someone who's optimistic, who is also very introspective, and I guess someone who's very, very introspective and knows how to reflect. I think those are the types of people who would do well with oncology. But I also think someone who has a good sense of humor. It's interesting because even patients, will have a really good sense of humor about things. So, sometimes you think that you're coming in and, you're feeling kind of glum, but the patient will, like, crack a joke that you may even sometimes think is, like, inappropriate for their situation, but
Right.
that's how you get through things. So I think if you can have a good balance of being very, resilient and have a sense of humor, but also, be introspective and be a sensitive person, I think that, that's a good fit for oncology.
Usually when new PA grads first come out of PA school, the first goal is to establish themselves within their clinical practice. And I know that you've been pursuing your master's. Of course, you just finished recently.
Yeah.
So what made you decide to further your education after pursuing PA?
I think because I have a lot of interests, and I also wanted to teach. So the first thing that motivated me was teaching, but also, like, I just wanted to learn more about the healthcare system. And I think it was really cool because this master's is based off of the public health school and the family and community medicine department at U of T. So I learned a lot about public health as well, and that kind of uncovered another interest for me. I also think that I wanted to learn a bit more about research in order to do things like the research project I'm doing now.
Did you have a lot of research background in your undergraduate degree?
I didn't. So I took one research opportunity program in my undergrad, and I don't really remember much about it. But when I found a topic that I was really interested in the past couple of years, I knew that I needed more skills to actually do something about it. So I think the master's degree really helped with that.
What do you mean by public health?
So looking at social determinants of health, looking at how poverty affects the health outcomes of a person, looking at how food insecurity affects people's health outcomes, even how, like, how political instability can affect people's health outcomes. So I think, the migrant crisis and refugees, it's something that's going to continue to progress in the next few years. And just looking at the health of undocumented people within our own city. So those are things that I want to learn more about and try to take more of an activist role on in the near future.
You speak to what your project was for your master's.
There's two projects that I did. So the first one that we had talked about is more of a teaching-based project. So I just completed my, practicum or capstone project where I designed the framework for a course that I plan to propose in a PA program. And it's basically about reflective practice and mentorship. So, physician assistants and really all healthcare professionals will need to be efficient in self-directed learning in order to kind of flourish and continue to grow as professionals. I think for PAs in particular, it's really important because PAs kind of come out of school and get right onto the job, have to try to secure employment, but also survive this steep learning curve. And because they're not doing residency, there's no structured learning after you graduate. So really, to have reflective practice skills is to be able to identify what are your learning gaps, why was a case so difficult, and be able to go back and think about it later on and figure out how you would approach the case differently next time. So, in order for PAs to continue to grow, it's really important to have that skill. And I actually saw a study that showed that, PAs who didn't have as much self-directed learning skills, if they weren't in a supportive work environment, there is a risk of leaving the career because, they have trouble coping. So I ended up designing a framework that kind of introduces reflective practice, but in an interactive way that's attractive to students, and it's been found to work in other programs. So my hope is to kind of, maybe start getting this developed and maybe roll it out in the next few years.
Can you speak to the interactive component specifically with mentors?
Yeah, so I think, reflective practice alone is not very attractive or relatable to students. There's a systematic review that shows that. I think even just thinking about it myself and interviewing other students, when you're trying to learn all these other things, medicine, clinical skills, then learning how to reflect and trying to do reflections on the side becomes very difficult. But when you add the mentorship component, it's almost like it brings the reflections to life, and it gives context to it. So, you end up developing a relationship with a practicing PA, and kind of you're able to bounce your ideas off of them, and they can teach you where reflection comes into play. We end up having to make a transition in our identity from just being, maybe a patient to then being a student in healthcare to then being a healthcare professional. And, having a mentor allows you to be more conscious of that process and maybe reflect more purposefully on that.
And what's the second project that you're working on, or that you worked on?
Yeah, so the second project is actually a research project. So it's the one that I'm currently the co-PI for at work. So I'm working with one of the psychiatrists in our unit, and we're looking at meaning-centered psychotherapy and existential distress. So right now it's the early stages, and what we're trying to do is explore the prevalence of existential distress in oncology inpatients, and to see if it has any effects on healthcare outcomes, so their own outcomes, hospital use, length of stay, quality of life for them. Mm-hmm. And, if we do have findings on this, then perhaps we would take meaning-centered psychotherapy into the hospital, because at this time it's just kind of in clinics supporting more of the well patients.
Okay. Can you clarify what you mean by existential stresses?
Yeah, so existential distress is basically a loss of meaning in life.
Okay.
So people can go through depression, they can go through anxiety, but existential distress is when typically when you're suffering and you're not seeing the meaning in the suffering or you've lost all meaning in life. So that's what we're trying to explore in inpatients at this time. I don't know.
So what's your recommendation for anyone that's interested in pursuing the PA profession?
I think that, if there weren't any other considerations in life, I would say go for it, because I think that it's a really flexible career. I think the possibilities are endless. I think that it's, you get to practice medicine. You're well compensated. But I also think that because it's such a new career, at least in Canada, that you could do anything with it. And I think that's what's fascinating. Like I didn't think that I would be, designing a course or doing research about existential distress, but also treating cancer patients. Like I think that that's a really cool evolution within the last 5 years of my career. But I also think that it's important that if you are considering it, that you need to be open to being an advocate and being a trailblazer. And I think that there are a lot of challenges to that, but also a lot of really rewarding things about it. So, and I also think that if you are a PA student and you know the field you're interested in, be vocal about it. When I was in clerkship, I think that there were very well-meaning people who suggested to me, like, no matter what, if anyone asks you, say that you're interested in emergency, because there are a lot of jobs there for PAs, and you need a job when you graduate. So when I was in Emerge, a physician asked me, like, so what do you want to do when you graduate? And I said, like, in my head, I was like, I should say emergency. But I was like, no, I'm going to come out and say it. And I said, I want to be in oncology. And I know, like, it probably sounds strange, and it probably sounds like there's no market for PAs there. And he was like, no, let me introduce you to some people. And he introduced me to my supervising physician. So, I think that if you feel passionate about something, just go for it.
Thanks so much for watching. If you have any further questions for Claire or for myself, please leave a comment below. I respond to every single comment. Don't forget to like and subscribe for updates. And if you want to read the blog post version of this interview, please visit canadianpa.ca /oncology PA. Until next time.